So I will start now. Bismillah. Today, the topic for the lab is factors affecting response of the weight. Okay, so factor affecting response of drugs. If you see this slide, I have given a picture which shows the therapeutic window. So whenever you require the response from a dose, its plasma concentration must be between desired response and adverse effect, or we can say minimum effective concentration to maximum safe concentration. This is the therapeutic window. There are various factors which affect this one. So we will discuss about all these factors and how they are affecting the response of a drug. First of all, the variation in drug response may be among individual. For example, one person is getting effect, whereas other is not getting effect, or they have different response to a similar drug, or it may be in the same person at different time during the course of treatment. For example, the person who is taking any drug, he is showing no side effects initially, but after some time, due to cumulative drug effect, or you can say due to repeated administration of drug, he may produce more pronounced effect, or he may show some drug adverse effects. We will see all these types and various factors. Now, the response produced by any drug may be quantitative or may be qualitative. What does it mean quantitative? The action of drug is greater or lesser, depend on various factors. For example, if you are giving insulin therapy to a patient, if you are giving higher dose, there will be better control of glucose level. If you are giving lesser dose, then he may be having a hypoglycemic state. So the effect depends on the dose here. Now, what if you give more than the therapeutic dose? There will be hypoglycemia, so greater than what we are expecting. Now, second is qualitative. Qualitative means the response of the drug is altered. For example, in case of aspirin, can anybody say what we have seen in case of aspirin? Qualitative means the effect is different than that depends on the dose. We have seen this in response. What effect you have seen with the aspirin, with the dose? Okay, I will say. In case of aspirin, when you are giving at a very low dose, it works at antiplatelet. It has antiplatelet effect. But if you are giving at a higher dose, it will work as analgesic, antipyretic, and on still higher dose, it will work as anti-inflammatory. Sometimes it may be idiosyncrasy, means unexpected results. We are not expecting this result from the drug itself. Now, why these factors are important and why we are reading all this is because in drugs with a narrow therapeutic window or therapeutic ratio, doses which are inactive in some patient may produce toxicity in other. For example, any drug is having narrow therapeutic window. If you see this picture, this window is quite large. But suppose this therapeutic window is very narrow. So what happens if there is suddenly any effect on the plasma concentration of the drug? It will shoot above the maximum effective concentration, or you can say minimum safe concentration. So if it overshoots it, then what will happen? It will produce the toxic effect. So what factor can affect it? So it may be cumulative effect, it may be hindrance in the metabolism and excretion of drug. So drug will be accumulated in the body itself. Next, in case of emergency, we require rapid effect. So the factors which governs the absorption or distribution can have a significant impact. For example, in case of nitroglycerin, if we generally, in case of angina pectoris, we are giving nitroglycerin by sublingual dose. So what happened in sublingual dose? It will be absorbed, sublingual, below the tongue. The tablet is placed below the tongue. So the drug will directly absorb into the blood circulation, and this will avoid the first pass metabolism. If you give it orally, then what will happen? It will go to the GI tract, it will be absorbed in the blood, go to the liver and destroyed. So if you're giving it sublingually, then it will avoid the first pass effect and other absorption related parameters. And now the third important thing is, for optimal response to a drug, the dose should match the individual patient. What does it mean? The comorbidities present in the patient should be taken care of before deciding any dose. Even you have to take care of the age also, his lifestyle also, and his weight, BMI, age, sex, and comorbidities. All these factors you have to take care before deciding the dose. So that's why it is very important to study about the various factors affecting the response of the drug. Now, why there is difference in individual to individual or in the same person? What is the cause of difference in the drug response is, first, different concentration of the drug at the site of action due to difference in the pharmacokinetics parameter of the drug. So if there is different concentration of the drug at the site of action, its effect may be higher or lower. That will be decided, and here the pharmacokinetics, absorption, distribution, and in distribution the plasma protein binding factors and the metabolism and excretion, or metabolism excretion together we can say elimination, will play an important role. Then different response of the patient to the particular drug concentration, that is the pharmacodynamic parameters, will cause difference in the response of it. So altogether, the difference may be either because of the pharmacokinetic parameters or because of pharmacodynamic parameters. So we will see the various factors which are responsible for variation in drug response. It may be dose, for example, aspirin. It will produce qualitative effect, whereas in case of insulin, it will produce quantitative effect. We will see in the next is route of administration. So is different. There will be different in the pharmacokinetic parameters, and it will affect the response of the drug. For example, a drug is given by oral route. So what will happen? It will be the tablet is going to disintegrate in the GI fluid, and here it may be destroyed by some of the some part may be destroyed by the then remaining part which is absorbed, that depends on its lipophilicity. So higher the lipophilicity, higher will be the absorption. Now it will be distributed, and now there will be plasma protein binding. So the portion of the drug which is reaching the site of action will be less than what is given. Now, the same drug, if it is given by intravenous route, what will happen? 100% of the drug is reaching the blood circulation. So there will be no loss due to absorption in there. Now, next is physiological factors. Various physiological factors we will see in the next diseases that may be renal, especially renal and metabolic diseases are very important, because these two organs are important in plays an important role in the elimination of the drug. So if elimination is hindered, there will be accumulation of the drug, and response of the drug may increase, or it may cause some adverse drug reaction. Now is environmental factors such as cigarette smoking, so it will affect. Then genetic factors, variation in genetic factor among the same race or inter-race variation is also there. Administration of the drug may produce more pronounced effect than the first drug. So this may be accumulation in the body. Then psychological effects, tolerance, and interaction with other drugs. We will see all these factors one by one in the coming slide. And I request you to take participation in the discussion whenever I ask for it, because this is lab, so we expect you to participate in the discussion. So if you have anything, just if I ask anything, just respond, please. Because in the last we will do some brainstorming also. So there I will require you to take active participation. Maybe age, sex, pregnancy, body size, lactation, and the food. Now we will go one by one. Dose. Now, when I say dose of a drug, does it mean a fixed dose? No. Generally, when we say dose, it's a range, 200 to 400 milligram. Now, there will be, based on the dose, the effect of the drugs may be different. It may be quantitative difference may be produced. So within this range, the effect quantitatively changes. For example, increases or decreases. If the best example for this quantitative difference is insulin. Now, insulin, as we all know, it is used in case of type 1 diabetic mellitus. In these type of patient, they have hyperglycemia, so they have increase glucose level in the body. So when you give insulin, the decrease in the glucose level depends on the dose. So this is a very good example of quantitative difference. Now we will see in second qualitative difference. This is seen in case of aspirin. We have just in the previous lecture, just 1 or 2 weeks ago, we have studied about the non-steroidal anti-inflammatory drug. So aspirin is a non-steroidal anti-inflammatory drug which is also having antiplatelet effects, analgesic and antipyretic effects. So the effect depends on the dose. For antiplatelet effects, generally we are giving this to those patients having cardiovascular diseases. For its antiplatelet effects, the dose is 150 milligram. For analgesic and antipyretic effect, the dose of aspirin is 300 milligram. Whereas for anti-inflammatory drug, it is 3 to 6 gram per day. Now, the same drug is producing different effect at different dose. So this is a very good example of qualitative difference because of the dose. So the factor here is, which factor is responsible? The factor responsible is the dose, how much dose you are giving, that is responsible. Because generally in short notes or in you can see this OSPI, they will ask which factor is responsible for qualitative difference of aspirin, and can you give the example? So the factor is dose, and the effect is it produces antiplatelet effect at 150 milligram and analgesic and antipyretic effect at 300 milligram, and on the dose of 3 to 6 gram, it will produce anti-inflammatory. Next is route of administration. So there are various route of administration, or can you tell me what are the various route of administration? Anybody?
Oral, intramuscular, and IV.
Okay.
Subcutaneous, intradermal.
Yes. So topical, oral, and
Parental.
rectal also. Rectal will be in the oral. Okay. So you know what are the various route of administration. So when it is given orally through the mouth, what will happen? Various pharmacokinetics parameter will take place. If it is given in tablet form, so it will be disintegrated, dissolution take place in the GIT fluid, then it is absorbed, distributed. But if it is given intravenously, what will happen? It is directly going to the blood flow. So what the factors affecting the absorption will be avoided. Now we'll see one by one what happens. So first is the plasma concentration of a drug is very important in producing the effect of a drug. So if absorption, for example, in case of sublingual or intravenous nitroglycerin, higher concentration will reach the blood than the oral, and it will produce higher effects. Why there is a difference? As I said before, if you give it by oral route, the drug will be absorbed. So various factors such as the lipophilicity, the acid, the pH of the gastric fluid, all these factors come into play. absorption from the oral route, there will be the blood will move to the liver, and there may be hepatic metabolism, or you can say there will be first pass metabolism. So it will decrease the concentration. So first of all, the route of administration will decide the concentration of the drug that is reaching the blood. So plasma concentration affected by the. So higher the plasma concentration, more will be the effect. So highest plasma concentration can be reached by intravenous. Everything, 100% of the dose will reach the blood. Second is onset of action. So sometimes we require very fast onset of action. For example, in case of emergencies, suppose a person is having attack of angina. So in case of angina pectoris, we require quick dose or rapid onset of action from the nitroglycerin. So drug has to be given by a route that will produce rapid onset of action. For example, in intravenous or sublingual dose of nitroglycerin produce a rapid action onset of action. Then the oral, because oral there will be delay due to disintegration, dissolution, and then absorption, and various factors will take into play. So if you require a rapid onset of action, the best route is intravenous. In case of angina pectoris, we generally give nitroglycerin sublingually, because the oral cavity is having very high vascularity and drug will be directly absorbed. And these do not require any specialized intervention or do not require a person to give it intravenously. So the patient himself can take in case of emergency. Then is the nature of the drug will affect the route of administration, and nature of the drug will affect the concentration of the drug reaching the blood. Higher the lipophilicity, higher will be the absorption. Next, different route. Then next factor is different route may produce different drug effect. Earlier we are talking about the same effect. Here we'll talk about the difference in the effect itself. For example, magnesium sulfate, when given by oral route, it is producing laxative effect. Okay, and it is not absorbed in a significant amount from the GIT tract. So it is producing laxative effect. Whereas if it is given by intravenous route, it will produce CNS depression and hypotension. So if a question is asked, what is the difference in the effect of the magnesium sulfate in the body and which factor is responsible? So you can write the factor responsible is route of administration, and the difference is because of the route. In case of oral administration, it will produce laxative effect, whereas for intravenous route, if it is given by intravenous route, it will produce CNS depression and hypotension. Now, next example is about the vancomycin. Vancomycin, if it is given orally, it will produce vancomycin. You know it? It's an antibiotic. Okay, you must have studied this one. So vancomycin, when it is given orally, it acts locally in the GIT only. But if it is given intravenously, it will produce systemic effects. Now we will talk about various physiological factors. So we will talk first about the age. So generally, the tablets available in market contains the adult dose, unless it is recommended that this is for the pediatric patients or this is for children. Generally, for example, if you find Panadol, it is having dose for the adult, and adult means people between the age of 18 to 60 years. Now, there are some factors related to infants. We will talk about infants, so and young children's, and then we will talk about for the old people also. So geriatric patients. First, infants. They have increased response to some drug due to increased drug concentration because of decreased elimination. For example, so what does it mean? The drug, if you are giving the same dose of the drug, elimination is not developed as that of the adult. So what will happen? This there will be accumulation in the drug in the blood because of lesser drug elimination, and hence they will produce higher response, or it may produce adverse effects because of, or it may produce toxic effects because of a higher concentration of the drug in the blood. Now, there is an announcement that this meeting may end in 10 minutes. So I request all of you to log in again after 10 minutes when this meeting ends, and we will discuss the other factors. So let's see some responses. Decrease hepatic drug metabolism in newborns. So in newborn, the hepatic or drug metabolism by the liver is not developed, or you can see the enzymes are not developed as much. So what will happen? The drug, they may accumulate in the body and produces the toxic effects. For example, in case of chloramphenicol, due to lack of glucuronidation reaction, accumulation of toxic chloramphenicol metabolism will take place, and it will produce gray baby syndrome. Now, the question that can be asked is why, which factor is responsible for gray baby syndrome with the use of chloramphenicol? So the factor is age, and why it happens, and the reason is because of decreased glucuronide conjugation in the body. Next is theophylline. Because of its hepatic decreased hepatic metabolism, it will produce theophylline toxicity, which is manifested by nausea, vomiting, tremors, and insomnia in infants and young children. Now, next factor is low glomerular filtration rate and tubular secretion. What is this glomerular filtration and tubular secretion? Can anybody respond? Okay, so I will tell you. This is related to the urine formation. You must have seen in the, or part of excretion from the nephron. So the newborns are having low glomerular filtration rate and decreased tubular secretion. So drugs which are exclusively excreted by glomerular filtration or tubular secretion, they will not be eliminated out of the body as such. So they will be accumulated in the body and produce higher effects or toxic effects. For example, gentamicin, since there is low GFR, it will be accumulated. So its T half will be increased. Similar is with the penicillin, which is excreted through the tubular secretion. Now, next is regarding the age itself again. So we will talk about it. The adult dose, we all know, is for the people between the age of 18 to 60. And if we have to calculate the dose for the children, there are various factors. For example, Young's formula. You must have studied the calculation of dose for the children for less than 12 years. We generally use Young's formula. So dose is equal to age upon age plus 12 into adult dose. For example, a child of 8 years of age. So 8 divided by 20 into 100. So 5 into 8 is equal to 40 milligram. So if the age of the dose of the adult dose is 100 milligram and the child is of 8 years of age, then his dose will be 40 milligram. But here we have to consider other factors also, because in infant dose must be learned as such and not derived from any formula because of some factors. So this can be done for the children, but for the infants, we have to take care of other factors also. So we will see about some difference between the newborns and the adults and what factor are responsible. For example, as we have studied just now, low glomerular filtration because increase in the concentration of gentamicin, and it is because of the low elimination, and it increases the T half. So T half of the drug is increased because of accumulation. Second is low glomerular secretion. It may leads to increased T half of the penicillin. So effect of the penicillin will be for a longer duration. So you have to increase the dose interval in both the cases. Otherwise, there will be chances of production of toxic effects. Next is immature hepatic drug metabolizing system. So we have seen in case of chloramphenicol, we have already discussed this. Due to lack of glucuronidation reaction, there will be accumulation of toxic chloramphenicol metabolites, and it may lead to gray baby syndrome. Next is immature blood-brain barrier. So the newborns or infants have immature blood-brain barrier. The blood-brain barrier of the adult prevents most of the drugs to enter into the blood, into the brain. Most of the things, foreign things, to enter into the brain. So it prevents the toxic effects. But in case of infants or the newborns, this is not developed fully. So what will happen when you give sulfonamides to the newborns? The sulfonamides displaces bilirubin from the albumin. So albumin, which is a plasma protein, sulfonamide drugs have higher affinity than the bilirubin. Bilirubin is already present in the blood, and it is found in the binded form with the albumin. So when you give sulfonamides to the newborns, these sulfonamides have higher affinity for the albumin, and it will bind to the albumin and displaces the bilirubin. Now, these newborns or infants' blood-brain barrier is not completely mature. So this bilirubin now have the permeability to cross this blood-brain barrier, and it produces a condition called kernicterus. So here the factor is age and cause is displacement of bilirubin from the plasma protein called albumin. Now, next is in case of newborns or infants, there is decreased absorption of oral drugs because of decreased gastric acidity and slow intestinal transit, slow peristaltic rate. Now, they also shows increased rectal absorption and increased dermal absorption, transdermal absorption, because the thin skin is thin and more permeable. Whereas in case of rectal absorption, there is more the the thinning of the mucosal lining and more permeability causing response in old age. Next is gentamicin. Gentamicin generally shows gentamicin toxicity in those patients who are having renal impairment or any problem in related to the kidney, because as we have seen this in children, that it is exclusively or mostly eliminated through the kidney by glomerular filtration rate. So in adults, because of renal impairment, there is decrease in glomerular filtration rate, and it may leads to accumulation of the drugs. So if you do not adjust the dosing interval or the dose, the drug may be accumulated. The drug will accumulate and causes gentamicin toxicity. Next is beta adrenergic receptor blockers such as propranolol. There is decreased response in old people. This decreased response to drug acting on is due to less number of adrenergic receptors in the body. Next one, sex or gender. So the effect of drug may be different in male in comparison or male than the female. Let's see some effect. Beta blocker interfere with sexual activity in male only. Second, low dose aspirin. It has been found in research and seen with constant observation to different persons that the low dose aspirin reduce the risk of heart attack in men but not in women. So this is one of the example which is due to the difference in the sex. So male are produced, if you are giving low dose aspirin to the male, the risk of developing heart attack is reduced. Then is opioid have greater analgesic effect in women than men. So, and next is thalidomide is teratogen when given to pregnant ladies. So this effect does not occur in men. I should not have written this one. This effect does not occur in men because only women can become pregnant. So thalidomide, you remember thalidomide? We have studied this in adverse drug reactions. Thalidomide is a drug which cause phocomelia. Then see like the babies which are born and mother has taken this thalidomide during the pregnancy period, the babies were born with fin-like limbs, or there were no limbs at all. So we have studied this in adverse drug reactions. So this can be seen only in female. So the effect may be on the fetus only. Fetus may be male or female. Next one. Body size. The next physiological factor is body size or mass. Now, the body mass affect the concentration of the drug at the site a site of action. So small mass, there will be, if body mass is less, there will be lesser volume of distribution and higher plasma drug concentration. So higher the plasma drug concentration, higher will be the effect. Then second is, if the mass is more or the person is very obese, there will be increased volume of distribution of the drug and there is more volume of distribution, then what happened? There will be lesser plasma drug concentration. Now, whenever we calculate any dose, we are calculating a dose for the man who is having an average weight of 70 kg. Now, for exceptionally obese people or whose body mass index is more than 25 or 20, overweight, obese, 25 or 29, or those who are having very lean body, or we can say underweight, we calculate according to this formula. Individual dose is equal to body weight upon 70 into average adult dose. Now we will talk about the pathological factors, the diseases. So we know that the disease state or the comorbidities present in the patient, already present in the patient, will affect the elimination of the drug mostly. So if there is any pathological state, there will be decrease in decrease or increase in the effect of the drug. For example, some drug act only when there is a disease. For example, aspirin in fever, antipyretic effects. So if there is fever, then only it will decrease and bring the body temperature to the normal, because it will reset the thermoregulatory center in the hypothalamus. We have studied this. But if you are giving aspirin or any non-steroidal anti-inflammatory drug to a person who is having normal body temperature, will it leads to hypothermia? No, it will never, because it will reset the thermoregulatory center to the normal in the, so it will not cause any hypotension. Second is beta agonist in bronchial asthma causes bronchospasm. Next is sensitivity to some drug may increase, or we can say supersensitivity in some diseases. For example, in case of thyrotoxicosis, there is increased sensitivity to the adrenaline. Next is pharmacokinetics of some drugs are affected by disease. Iron, for example, in case of anemia, iron absorption is increased. Next one, disease of liver or kidney can affect elimination of drug. For example, gentamicin, we have already seen this gentamicin, if there is, it is mainly eliminated through the GFR. So if GFR is affected, there will be its accumulation in the body, and it may produce higher effect or even the toxic effects. Gastrointestinal diseases, NSAIDs can aggravate peptic ulcer. So we know that when in case of peptic ulcer, if you give NSAIDs, it may further deteriorate the condition, because it suppresses the prostaglandin, which is protecting the mucous lining. Next, in case of liver diseases, which affect on, it is generally affecting the pharmacokinetic parameter. First one is bioavailability of drug having high first pass metabolism is increased. For example, propranolol. So propranolol, which is a beta antagonist, which is when given orally, it undergoes first pass metabolism. So If the liver is not working properly or there is liver disease, there will be lesser first pass metabolism. So the drug will, or in simple what we can say, there is lesser degradation of propranolol. So more drug will be available, and that's why there is higher bioavailability of those drugs which are undergoing first pass metabolism in case of liver disease. Second, serum albumin if decrease, there will be higher free fraction of acidic drugs. For example, warfarin, because we know that acidic drug bind to the plasma protein called albumin. So acidic drug, most of the acidic drug bind to the albumin, and those drugs which are, so the action of the drug is produced by those drugs which are in free form, because conjugated or binded form drug are not available for producing action. So whatever is in the free form, that will produce the effects. So whenever in any disease condition there is decreased serum albumin, the free fraction of the acidic drug will increase and there will be higher effect. This has been seen with a drug called warfarin, which is a anticoagulant drug. Then is decrease in metabolism of such drug causes increased concentration of the drug in the plasma. So if any in case of liver diseases, if the metabolism is decreased, you have to decrease the dose of the drugs, otherwise this drug will produce adverse effects or toxic effects. This has been seen in propranolol. That's why those drugs which are having narrow therapeutic window, we have to consider the comorbidities also before giving any dose. Now, there are some drugs which are called prodrugs. Can anybody say what are prodrugs? Can you respond? What is prodrug? Can anybody say what is prodrugs? Okay, prodrugs are those drugs which are not effective as such, but they are converted into active form in the body. So these are converted into active form in the body by the liver. So if there is liver disease, what will happen? These drugs will not be converted into, products will not be converted into the active metabolites. So these are less active in case if the person is having liver disease. Then in case of kidney diseases, there is decreased clearance of the drugs that are primarily excreted unchanged in the urine. So we have seen the example of aminoglycoside type of antibiotics, gentamicin. Then is in case of kidney disease, there is decreased plasma albumin also. That's why in case of acidic, most of the time with the acidic drug, if there is decreased plasma albumin, so there will be lesser binding of drug to the plasma and more free fraction will be available to produce the effects. Next is increase, in case of kidney disease, there is increased permeability of the of the blood-brain barrier to drug, and it would produce more CNS effect, and it has been seen with the morphine. So morphine, in case of due to increased permeability to the blood-brain barrier, morphine produces more sedation. Next is heart failure. So when there is heart failure, there is increased volume of distribution of some drugs due to edema. So there will be decreased elimination of drug due to renal and hepatic blood flow also. So it will affect the concentration of drug in the blood. Thyroid gland diseases. In case of hypothyroidism, there is increased sensitivity to digoxin, where in case of hypothyroidism, increased sensitivity to digoxin, whereas in case of hyperthyroidism, it may leads to arrhythmic action of epinephrine and digoxin. Next, we will talk about the environmental factors. So environmental factors also affect the concentration of the drug. Yes, environmental factors such as insecticides or smoking habit or food or use of some drugs for recreation or some for making the, for example, steroids taken by the people who are going to gym or bodybuilders. So these all environmental factors may affect the plasma concentration of the drugs. For example, insecticides and cigarette smoking causes enzyme induction. So when it causes enzyme induction or induces the enzymes, there will be more drug metabolism. When the drug is metabolized more, there will be lesser plasma drug concentration and efficacy. Next is some food interfere with the absorption of drug. For example, if ampicillin is taken with food, it will be lesser absorbed. Or you can say when tetracycline is given with calcium or milk, then it will be absorbed less because it may bind to the calcium and form a complex which is not absorbed. Then corticosteroids taken as a single morning dose cause less pituitary adrenal suppression also. Now we will talk about the genetic factors. So those who are having atypical pseudocholinesterase, there will be long succinyl choline apnea. Second, some people are having glucose 6-phosphate dehydrogenase deficiency. In those patients, if you are giving primaquine, which is an anti-malaria drug, or sulfonamides, it may lead to hemolysis and bleeding. So you have to, when you are prescribing primaquine and sulfonamide, you have to consider these genetic factors. Another effect is acetylation. Acetylation is one of phase 2 reaction of drug metabolism. Some people are slow acetylators and some are fast acetylators. So in case of, for this, a very good example is slow acetylators. So when they are slow acetylators, then there will be slow metabolism or slow elimination of isoniacids, and there will be accumulation or higher concentration of the drug in the plasma, and it may lead to side effects of the isoniazid. So when you are prescribing isoniazid, this is it's a well-known drug for tuberculosis. So when you are giving it, you have to consider whether he's to adjust the dose. Next is race. So blacks require higher concentration of atropine to dilate their pupil than the American race. Or another example is beta blockers are less effective as antihypertensives in Africans. So this is the difference in the race. Next is cumulative effect. A drug will accumulate in the body if rate of administration is more than rate of elimination. As I said in the initially or in the previous slides, that cumulative drug effect is the repeated administration of drug may produce more pronounced effect than the first dose. And why this happen? Because you are giving more drug is administered than what is eliminated. So rate of administration is more than the rate of elimination. So slowly eliminated drugs are liable to accumulate to cumulative toxicity. For example, prolonged use of chloroquine causes retinal damage. So in case of prolonged use of chloroquine for a longer dose, it may lead to cumulative toxicity, and the effect is on retina. It may damage the retina. Psychological effect or placebo effects. So what is, first we will discuss what is placebo. Can anybody say what is placebo? Okay, placebo means a tablet containing everything except the drug. So it is not having nothing, no drug inside it. So these are the inert substances. It works psychologically. For example, if generally they induce psychological effect, for example, release of endorphin in brain and cause analgesia. And most of the time they may produce response equivalent to the active drug. You must have seen this, that in the family, some, especially the old people will say, no, I don't get effect from this drug. Bring me the drug which is yellow colored. I used to take I always take. So if you give the effect is because of the psychological effect. If you give that yellow color, they will have the effect. Next is tolerance. So tolerance is the requirement of a higher dose of a drug to produce a given response. It may be natural or it may be acquired. Natural, which is produced initially in some individuals who are hypo-responders to certain drugs, for example, to beta-adrenergic blockers. So some people require higher dose right from the beginning than the others. And then second is acquired. This is because of repeated use of the drug in an individual who is initially responsive. For example, morphine. So why this occurs? That because when a drug has multiple actions, or tolerance dose do not develop equally to all the actions of the drugs. For example, so this meeting will also end in 10 minutes. I request you to log in again after 10 minutes. Tolerance occurs to analgesic action of morphine, but not its constipating and mitotic actions. The next is cross tolerance. It is the development of tolerance to pharmacologically relative drugs. For example, alcoholics are relatively tolerant to general anesthetics. So those who are taking higher concentration of general anesthetics. So what are the mechanisms of tolerance? It may be pharmacokinetic tolerance, or it may be pharmacodynamic tolerance. It may be due to the decreased concentration of the drug at the site of action because of increased elimination on chronic use. For example, barbiturates and carbamazepine induces their own metabolism. So when you giving it repeatedly for a longer duration, they induces those enzymes which metabolizes their itself. So their concentration will decrease on repeated use. Next is pharmacodynamic tolerance. It is when the cell of the target organ becomes less responsive due to down regulation of the receptors. And that has been seen with the beta adrenergic receptor blockers. On chronic use or repeated use for a longer duration, it may cause down regulation of the receptor. Hence, they will produce lesser effect, or they may require to give higher dose. Next is tachyphylaxis. That is the rapid development of tolerance when dose of a drug are rapid. Mostly seen with the indirectly acting drugs such as ephedrine. This is because of depletion of stores of neurotransmitters. So this ephedrine causes release of the neurotransmitter, norepinephrine. So when you are using it constantly or rapidly, then rate of release will be higher than the rate of formation. So whatever is there in the store, that will be depleted and it will not produce the effect. Now this is the last, I think this is the last portion of this lecture, and then we will do some brainstorming. So we will see some drug interaction. So when drug interaction is seen when you are giving 2 or more drugs simultaneously. The effect may be addition of the effects. 1 plus 1 is 2. It occurs when you are giving 2 drugs which acts by the same mechanism. For example, when you give aspirin or paracetamol, there will be increase in their effect because both are COX inhibitor, cyclooxygenase inhibitor, non-selective. So both are producing analgesic effect by inhibiting the cyclooxygenase enzyme, although aspirin is by COX-1 and 2 and paracetamol is by COX-3, but ultimately they are going to inhibit cyclooxygenase enzyme. So why, if they are both are having same mechanism, why we are using 2 drugs simultaneously with the same mechanism? Generally, individual drug to decrease their adverse effects. So we are increasing the effect of a drug without increasing their adverse effects. So we are using 2 drugs, both will work, and so effect will be clubbed, but their adverse effect will be lesser because we are using these drugs in lesser doses. Next is synergism. That is 1 plus 1 is more than 2. This is seen when 2 drugs are producing their effect by different mechanisms. For example, theophylline and salbutamol produce bronchodilation, but they are working through different mechanisms. So their combined effect is more than the individual effects. Next is potentiation. So 1 plus 0 is equal to 2. You are giving 2 drug, but second drug is not producing any effect, direct effect, but it will potentiate the effect of the first drug. For example, when you are giving acetylcholine with physostigmine, acetylcholine is the main drug which produces all cholinergic effects, but physostigmine will not produce any cholinergic effects. Then why we are giving physostigmine? Because it potentiates the effect of acetylcholine. So how it will potentiate the effect of acetylcholine? By inhibiting acetylcholine esterase enzyme. So what is this acetylcholine esterase? Do you remember this enzyme, acetylcholine esterase? Can anybody respond? Come on, come on. I know you know this. If nobody is responding, I have to respond. So acetylcholine esterase is an enzyme which is responsible for degradation of acetylcholine into acetyl moiety and choline moiety and terminates its effects on the receptors. So when you give physostigmine, it will go and bind to the acetylcholine esterase and it will not allow it to break acetylcholine. So there will be increased life of acetylcholine and there will be more effect of the acetylcholine for a prolonged duration. That's why it is called potentiation of the drug effect of other drugs. So here for physostigmine is not having any cholinergic effect, but it is potentiating the effect of acetylcholine by inhibiting the acetylcholine esterase enzyme. Then is antagonist. Antagonist, opposite effects. So it may be of 4 types: chemical antagonist, physical antagonist, pharmacokinetic antagonist, and physiological antagonist. First, we will see chemical antagonist. Hydrochloric acid and sodium bicarbonate. So you know ENO or some sodium bicarbonate type of drugs are available in the market, which are used when the person is having hyperacidity. So you will give, so hydrochloric acid is an acid, whereas sodium bicarbonate is a base. So when you give, the patient drink sodium bicarbonate or take sodium bicarbonate, this base will react with acid and neutralize it. So there will be neutralization of the acid by a base. So this is called chemical antagonist. There chemical reaction take place in this. Second is physical antagonist. What is physical antagonist? Some drugs, instead of say some drugs, I will give you a direct example. When somebody take poison orally, we used to give activated charcoal. This charcoal, when given immediately, it will absorb. It will not absorb. Listen, the word is adsorb. Adsorb means it will take the drug, or the drug will stick to the surface of the charcoal. When it is adsorbed on the surface of the charcoal, it will not be absorbed.